Hi and good evening, all healthcare providers. Hopefully, everybody's doing well. Today was just I try if I could share some information regarding transfer shots, or we can say on the short axis protocol of carotid artery or CCA. Doesn't matter if it's right side or left side, but I thought it's going to be important if I could share one of the protocol on the transverse carotid arteries with you guys. Let me share my screen with you guys and we can talk about that a little bit. And I'm sure that's gonna help you guys. If you guys are okay, this is one of the carotid arteries. So if we look to, we have to work on our landmarks. So for us, this is very important to see what are the landmarks from where we scan something. So like for example, on this images, we're looking for carotid artery. So for the carotid artery to put them on the segments, to divide them by the segments, for example, just to specify the disease, the pathology, any kind of pathology it is. So we have to put them prox, mid, and distal portions of the carotid artery or common carotid artery. So for us, the most important is if we're looking, we're scanning the carotid arteries on our neck, if it's right side or left side. So most probably the best is if you could use your jugular vein as a this one, we can see it here on this image. So if we could use jugular vein as a acoustic window, so this way we will have two things which will remind us two things. Number one, it will be an acoustic window. Number two, we're going to be looking if we will know our pressure, how much pressure we put on a patient's neck, because let the brain also to drain from venous flow. So if we put them pressure, if we collapse that jugular vein, that will make some kind of dizziness for the patient, and we don't want to see that. We don't want to experience that part. So here our landmark is the thyroid tissue. So on the proximal CCA, if we're looking for the transfer shots of the CCA, common carotid artery, so our thyroid tissue is one of our landmark. So this way we can tell either you may see like this much of thyroid tissue, or you may see a little bit of thyroid tissue, or with some of the people, it depends on the neck size. If somebody has a tall neck, you may not see the thyroid tissue because you may see only circular, nice, anechoic, clear borders, CCA with a gray shape, and then that will be a little bit thyroid tissue or maybe no thyroid tissue. But we have to distinguish between the proximal thyroid tissue and then proximal CCA, I'm sorry, and then mid or middle of that midline of that CCA, the next image. So this is our first image. To take it prox, after next image is our mid. So we have to see some changes in the thyroid tissue for the next image. Then that will indicate that we are in a mid portion of the CCA by the transfer shot. So this is our proximal. And this image, we want to see our artery, our common carotid artery or CCA. It has to be anechoic, clean, clear with no echoes, and also we want to see all the walls has to be very clean, clear borders. So there should be if there's any plug buildup or if there's any another aneurysm or anything, it will give us a different shape. And also with a plug buildup or stenosis or maybe compression from somewhere. So we want to see if it's not like a rounded, clear image. In that case, it will be. So this is a normal CCA. That's why we see it clean, clear, anechoic structure, like very rounded and circular structure. And meanwhile, we're looking for the surrounding tissues by the neighborhood. If you see any unusual structure in the area, for example, if you see any nodules or cyst in the thyroid tissue, you have to report that too. And meanwhile, also you're looking for the other muscles area. If there's anything you see, so we have to report it. Any pathology around. So our next image is color. So we have to put color on it. So with the color, if we miss here in the gray, for example, if there's a soft tissue plug buildup, but because of the 2D measurement with a black and white, we cannot diagnose it. So it's better to put color on. and then it has to fill completely with the color if it is a normal study. If it's not a normal study, if it's there's a compression or if there is any soft tissue plug buildup, which we were not able to see it on a black and white or 2D image, so with the color we will be able to see, because if there is any plug, if it's a soft tissue plug or compression on that portion, it will be a missing color, there will be missing flow, because it makes sense. It's any part, it will be no color. We will not be able to see a flow on that area. But keep in mind, one thing is very important. So with the color, pretend if this cell phone is my transducer. So of course, all of you know, we put the notch of the transducer always to the right of the patient, always on the linear probe. If you're scanning the left side or right side, doesn't matter, or anywhere in the body, any vascular, on the transverse shot, notch of the transducer always to the right of the patient. So when you put it on the neck area as a transverse, so try to make it more towards, then you will have a full color. Or no problem, make it completely away, but then you have to invert the color, because we want to see our arteries always to be in a red color, not a blue. That's worldwide accepted. It has to be the red color arteries for the normal flow. So if you put it 90 degrees straight with the skin, you will experience in this area, you will experience that there will be a missing color. That is a false positive plug buildup image, because we made it. It's all physics. If you are 90 degree, cosine of 90 is 0, and then Doppler shift on that area will be less or 0. So we have to be aware of that. Either make your transducer towards, let the sounds to go towards the flow, or make it away. So these two things will fix that false diagnostic images. So this is our proximal. So our mid, if we look to mid, this is our mid portion of the CCA. The thyroid tissue is the maximum tissue we see. So this is a maximum thyroid tissue. And I forgot to tell you guys, for the proximal, always I will put my cursor, or we can say the focal zone. It has to be always just at or below. Not too below, but above, always wrong. Because lateral resolution at the focus point is the maximum. So we put our focus point on the study area where our study is. So this is a maximum thyroid tissue. This is a landmark for transverse CCA mid. So let's put color also. If we look here, it's also anechoic, clean, clear. We don't see any problem. But again, we have to put color on to see this filled completely with the color. Next image. Okay, with the distal portion of that CCA, you may see thyroid tissue, you may not. Same thing like a proximal. We said we may see the thyroid tissue, we may not. But here on the distal portion, the easy point is if you're scanning left or right, doesn't matter. So go all the way, more higher and more higher. Go all the way, go to the bulbous area where it's not anymore rounded or circle. The CCA, it will be oval shape. It will be like an egg shape. So it's not circular anymore. And slowly come back. When you come back, you will find this structure, which is more circular. You may see thyroid tissue in the area, you may not. Like in this image, we don't see thyroid tissue at all. So this is the indication or landmark for our CCA distal portion, transverse. Let's put color on it. Okay, if you look to the color, color gain, it's okay. Color scale, it can be anywhere between 0.34 or 0.46 meter per second. That can be somewhere. It depends on the patient's situation. If a patient has a really hypertension or really they have polycythemia or something, so maybe we can increase it a little bit. It depends. Everybody is different. If somebody is really dehydrated or hypovolemia or maybe anemic, so it depends. Then you can play with that scale. So you can bring it down on those cases. And the color gain, normally I will put it between 50, but again, it depends. So this is just middle area, and from there you can just increase it or decrease it, depend on the situation. We don't want to increase that much to see too much aliasing on the area, but just to see that we are ruling out if there's any plug buildup. or aneurysm or any pathology. So if you look at this image, it's filled completely like previous image was this, and this is my color image. So this looks completely filled. So we'll rule out that there is no pathology in this specific study. I don't see anything. Next image will be the bulbous. Okay, if you look, difference between this, which was a distal portion, and if you look here, this is the bulb. So transverse CCA, the bulbous area, it's like an egg shape or ova shape. So it's not rounded anymore because it was rounded like here, but it's not rounded anymore. So that is our bulbous area where it bifurcate. So the CCA will bifurcate in this area to the ICA, internal carotid artery, and ECA, external carotid artery. So some of them will give blood supply to the face, to the nose, to the tongue, to the ears, temporal area, occipital area. So it will give to all this area. And then one another artery, which is the widest artery, which has more blood flow. So that will go to the brain, which is ICA or internal carotid artery. So the main purpose was and here mostly we don't see thyroid tissue at all. Mostly, maybe 1% you may see, but it's not possible. We don't see thyroid tissue. So this is a CCA, but in the bulbous area. So if I see any plug buildup or any other problems, we will be able to see it here. Mostly, plug can build up in any area, but mostly you will be careful to see a bulbous area clearly with a 2D measurement, with a 2D image, and also with a color, because mostly it happens in here. In the bulbous area where the CCA bifurcate on two arteries. So it's mostly happen in this area. So be careful to scan this. You can zoom it close by to see if there's any if there's any in the bifurcation area, if there's any plug buildup or any pathologies. We don't want to miss that. So let's put color on it. Okay, so this is a normal flow to see this blue in the bulbous area because it is a turbulent flow. Flow came from the CCA, it was narrow. The CCA lumen was not, the diameter was not too big when it come to the bifurcation, so it just become a little wider. So from there, it just bifurcate. So that just some of the blood is turbulating. It just that blue you see is just that flow is turbulating and go back to the towards the brain or towards the face. It depends where it is it on the IC or ECA. So this double color or two colors are okay, but we try to see maximum red, but a little blue is okay. That's normal. Even if you see that in the sagittal images, still that's normal flow. It's a turbulent flow because at the bifurcation or we see the turbulent flow in that area. And after that, we have to bifurcate this. Okay, so transverse CCA bifurcation. Okay, for us, it's important to see our ECA. This is one of the differential diagnoses between the ICA and ECA, internal carotid and external carotid artery. So my external carotid artery, if you guys know, thyroid tissue was here when I was scanning the CCA, proximal, distal. So we saw the thyroid tissue here, the trachea was here. So this means this ECA is more medially anterior. So it's more medially anterior. And then my ICA is more laterally posterior. It just go to the brain from there. It just go more higher, and then it go from in magnum area. It just enters to the brain. So this is more laterally posterior, and then ECA is more medially anterior. Let's put color on it because gray image may be not so clear. Let's put color to see if there is any pathology we can see. So if we look here, my ECA is smaller in the diameter or lumen is not that big, and then ICA is big. So that's why we can tell that 70 to 80% of the blood flow from the CCA, it goes to the ICA, and then that only 20% or 25 or 30% of the blood flow, it comes to the ECA. So from here, we can say a few diagnoses, a few differential diagnoses between the ECA and ICA. My ICA and the diameter, it's wider, bigger, and then ICA has no branches extracranial. The first branch is the ophthalmic artery, which is inside of the brain. and then it's posteriorly lateral or lateral posterior. So that's another third. The fourth one, the differential, we can say ICA is low resistant flow. It feed the organ. So we see a lot of blood flow in the in left diastole also. They don't touch the baseline. And then ECA is completely opposite of it. Diameter is smaller. Flow is a high resistant flow. It can be biphasic flow. It touch the baseline too. And the end of diastole, we don't see flow or we see a little bit of flow. That's two. Three, we see branches extracranially. We see branches of the ECA. For example, the first branch is superior thyroid artery. So we will be able to see that easily. And then the next one is, so it's a high resistant, it has a branches, it's anteriorly medial, the ECA. And then it is diameter is a smaller. So hopefully these will help you guys. Let's see the sagittal images. Just wait for the next video. I'm going to put it the next video. Have a good night.